and welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Bob Miller of Johns Hopkins and consultant editor for the JOP. In the May 2011 issue of the journal, we feature two original contributions on the topic of rural oncology. The first is a report from Varany and colleagues of West Virginia University who performed a patient survey exploring recruitment barriers for cancer clinical trials. The second is a first-person account by Dr. Laurence Heifetz, medical director of the Tahoe Forest Cancer Center in Truckee, California, near Lake Tahoe, describing the successes and barriers he has experienced since starting the program in 2006. I'm pleased to have Dr. Heifetz as my guest tonight for this podcast. Dr. Heifetz is a medical oncologist who was in private practice for 23 years in Los Angeles before coming to Truckee. I'm going to let him tell his story. Larry, thank you very much for joining me this evening.
Thanks a lot, Bob, for having me.
So, group practice in Los Angeles to solo practice in beautiful, tiny Truckee and a 25-bed hospital. I guess my first question, which I'm sure people have asked you before, were you out of your mind?
Absolutely, Bob. I was at Cedars-Sinai with a 9-doctor oncology group, Tower Hematology Oncology Medical Group. We were a wonderful, loving partnership, and I had done it for 23 years, and I was in my late 50s. And the idea was I really wanted to shake it up. I really needed to shake it up. So we said goodbye to Los Angeles and decided to move up to Lake Tahoe. At the beginning, I thought I could effect a little change. I was the IT geek in my group, and for a while I got involved with an electronic EMR for oncology-specific uses, and got into the business side of that for about 2 years, and I was a total and complete failure at it. And the community here became such a loving place where the doctors felt such a desire to have an oncology program that I just decided to roll up my sleeves and give it a try.
Mm-hmm. So it sounds like the local physicians were welcoming. Do you think they perceived that there was a real need for a cancer program in that part of California?
Yes. For 10 years prior to my coming up here, they had requested the board of directors to recruit an oncologist. The problem is that Truckee is a little town north of Lake Tahoe, which is a really wonderful multi-season resort. Mm-hmm. It's just about 30 miles from Reno, Nevada, which is a medium-sized city, and about 2 hours from Sacramento, California, which is a very serious university tertiary referral place with a lot of big hospitals. The problem is that we've got major traffic problems, major snow, real serious problems, where getting chemotherapy would require a patient to have to drive quite a few hours just for a shot of 5-FU, let alone radiation therapy. So they'd been trying to get an oncologist for a while. When I met the medical staff here, the desire was, let's do something a little different. Let's just not get a doc and hang out a shingle and start seeing patients. Let's really try to build a program that was creative and would stand out a little bit more. Mm-hmm. And that's what we think we did.
That really sounds visionary on the part of the hospital staff.
Well, the hospital was it's really interesting. When you come up here, you think, oh, a bunch of country doctors, what do they know? I mean, they are really smart guys. Mm-hmm. And they've got tremendous ingenuity, tremendous capacity to make do with little. And at the same time, there is a culture here to always do the best. So there's been a very serious tradition to develop outreach to referral places where you could make sure that your patient was safe.
Mm-hmm. It sounds like one of the decisions you probably have to make on a regular basis is the age-old question of whether you take care of something in your local community or whether you send it outside your community. Tell me a little bit about that. How do you make those kind of tough decisions?
It's a function of a few factors. One is, in terms of oncology, medical oncology, we have certain illnesses that we don't want to go near because we don't have adequate backup. you're not going to treat a patient with acute leukemia in our little hospital. The absence of full-time house staff and the necessary support that you need here to do that properly would make that an inappropriate thing to do. Mm-hmm. So that out of the chute limited certain cases. High-end sarcoma therapy requires real hospitalization backup. We can't do that. Mm-hmm. With those two exceptions, we can do almost anything else.
How about imaging, access to MRI and PET and things like that?
The hospital had an MRI machine and had a CT machine. It did not have PET. It became clear that PET was necessary, and they entered into an agreement with a mobile PET scanner, and that mobile PET scanner comes up every Saturday, and it is proven to be cost beneficial. I see. So that's what we do for imaging.
Now, in the article, you talk about 3 different fears that cancer patients face. Fear of disorganized care, fear of becoming a burden to their families, and the fear of receiving treatment that's not up to date. When I was reading the article, my perception was that these fears might be heightened for patients that are being treated for their cancer in a more remote area, such as where you practice. Tell me a little bit about how you and your program tried to address each of these 3 fears.
These 3 fears are universal fears, but out here in the middle of nowhere, they are extremely magnified. The first issue of addressing disorganized care is a common complaint that patients have. By the time a patient comes to the oncologist, the patient's been through a family practitioner, a surgeon, possibly a gastroenterologist. Mm-hmm. Quite a few docs get into the loop rapidly, and the patients are always worried that, well, does everybody know all the medicines that I'm on? Does everybody have the same past history? Does everybody actually have the same facts? And once I'm starting to treat the patient, does everybody even know what I'm doing? This is a universal problem. What we did was we opened up the project by having an electronic medical record, and we designed it so that the patients participated in the data entry and in the maintenance of that, so that when we see a patient, we are able to show their images. It's all digital. We're able to review their medications, and we demonstrate to them that every time we finish a chart, we just click on this button over here, and all these doctors, these are your doctors you want, right? All these doctors instantly get automatic fax. That just created such a sense of relief that the patients had. It was palpable. The issue of becoming a burden on their families was one that we addressed by getting some help from our community. One of the advantages of being in a small town is that the whole community rolls up its sleeves to try to participate with something as interesting as a cancer program in the middle of nowhere. And that created funding for hiring a full-time psychologist. With a full-time psychologist, we developed group and individual therapy, art therapy, an exercise for energy program with our physical therapy department, ACS's Look Good, Feel Better program. We teamed up with UC Davis's Cancer Center with a project called the We Care Peer Navigator program. It was for breast cancer. It's seasoned patients who had already been at least 2 years out with their diagnosis of breast cancer, being trained as peer navigators for new patients with breast cancer. We based our psychological project on an article published in Cancer in 2008 by Barbara Anderson out of Ohio State, where they did a randomized controlled study of stage 2 breast cancer patients who had either a psychological intake and nothing else, or a psychological intake followed by structured, organized cohorts of patients going through psychotherapy, physical therapy, diet, nutrition, counseling, stress reduction, all of that stuff in an organized way for 1 year. Mm-hmm. And there was a statistically significant difference in relapse-free survival and overall survival between the two groups. As far as I was concerned, I didn't need anything more to justify the investment in offering this to all of our patients. The last thing that was different was that the caregivers are always left out of the loop. I myself have always sort of expected the husbands or wives to kind of suck it up and deal. Well, that's really wrong. We've never paid any attention to their needs. Now we're paying attention to their needs, and we're putting together caregiver support groups. So those people who really don't know anything about filling out insurance forms or transportation issues or nutritional issues or their own concerns can finally have them addressed in their own peer group. Mm-hmm. We found that to be very, very successful. The last fear of getting yesterday's therapy is really heightened out here in the mountains, and we addressed that by doing something different. We identified disease-specific centers of excellence for us, and I'm just going to be politically incorrect by naming them. UC San Francisco has a really outstanding brain tumor program.
Sure.
UC Davis has an outstanding lung cancer program, and Stanford's got a pretty famous lymphoma program. Well, we started reaching out to these NCI-designated cancer centers and started sending patients proactively for second opinions with these diseases, and the patients had never even heard of a second opinion up here in Truckee. So they couldn't believe it. We started pushing these second opinions on patients for other diseases as well to these special thought leaders. The thought leaders in turn said, hey, these guys are pretty open-minded. They're believing in transparency. Let's develop a relationship with them. Mm-hmm. And that turned into the relationship that is our rock-solid relationship with UC Davis as part of their UC Davis Cancer Care Network.
Yeah, tell me a little bit about that, because I think that was really one of the more interesting things in your article. I think many people would probably find that surprising that you developed this partnership, and you talked about the virtual tumor boards. It just seemed like, being not that far from you, they might view you as a competitor rather than a colleague. So tell me a little bit about how that evolved and how it works right now.
Well, as I started developing this outreach to the universities, I found a couple of facts. First of all, a bunch of these guys all had weekend vacation places up in Lake Tahoe, and they said, come on, Larry, I want that job.
That's convenient.
How come you got that first? Okay. And then the Davis people have a singular expertise in telemedicine. They've really devoted a tremendous amount of energy to perfecting the concepts behind telemedicine. Concurrently with developing our program here at Tahoe Forest, UC Davis was working on a grant from the Blue Shield Foundation to develop virtual tumor boards. I had spoken to the doctors at UC Davis about this concept, and wham, they said, yeah, we're working on it. So we developed a way to communicate extremely effectively. I think most people, you're in an academic institution, so don't take it personally, but most guys in private practice, when they have to send a patient to an academic institution, it can wait up to 3 weeks before the institution agrees to see the patient. And frequently it's very difficult to connect verbally with the doctor you want to send the patient to, because there are all these roadblocks that exist. Well, we cut through all of that. We have a system. The UC Davis tumor boards meet every week for their disease-specific tumor boards meet every week. On Monday, it's GI. Tuesday, it's GU. Wednesday, it's thoracic. Thursday is breast. And Friday is GYN. 80% of all oncology is GI, GU, thoracic, and breast. So the vast majority of our patients are serviced by these 5 tumor boards.
So those tumor boards, those are the times they actually meet in Sacramento. They meet live.
Exactly.
Okay.
So what we created within this network of there are four hospitals in rural California who are part of this network. In our hospital, we created a room. It's a small little conference room that seats about 8 or 9 people. And on one wall, there is a TV camera in the middle of the wall. And beside the TV camera, on one side is a big flat screen TV in which we're all looking at each other, all the doctors participating in the tumor board. On the other flat screen TV, to the other side of the camera, is the TV set that is dedicated to the PowerPoint or the MRIs or the pathology slides, and they can be viewed and commented upon by all of the radiologists, by all of the doctors, and controlled by anybody at any of these sites.
So it's not just UC Davis doing the driving, if you will.
Exactly. But UC Davis is still the mothership on this. So what happened within about a year is that this is where it's my doctor's dining room. And this is where we all got to know each other, and where the Davis docs enjoyed the relationship with docs out there in the street, and the docs in the street really developed a partnership relationship with the academic docs. So now I can see a new patient on Monday, recognize that I need to get a consultation, and I can almost always get a case on a tumor board within a week.
And do the tumor boards, are you online with the other hospitals at the same time, or is it just you and UC Davis, and then does each of the hospitals take turns, or is it done all in one virtual community, if you will?
All of us at the same time. It looks like Hollywood squares on the one of the monitors.
Got it.
And it really works. We had to get over some technical difficulties. We learned about bandwidth and interference, but once we conquered those, we created a system that is very, very solid.
And this is something that you do several times a week if you have the cases?
Yes, and even if I don't have the cases, I participate by just having a sandwich and being part of the group. So we all became clinical faculty, and this is part of our set of responsibilities.
Now, you mentioned in your article that it sounds like the program's doing very well, and you've brought on a second oncologist, and you'll be opening a radiation facility. Tell me a little bit about how the community support has evolved. I mean, it sounds like there was a pretty high level of support to begin with, but what evolution have you seen over the last couple of years?
The community recognized that we needed to have radiation therapy. For a patient to get breast conservation, I'm not talking about mammocyte, but standard breast conservation, it takes about 7 weeks of daily radiation. We had young women who were holding down jobs out here in the mountains who chose mastectomy over breast conservation because they couldn't give up 2 months of work. To spend essentially 3 hours round trip getting their breast radiated. That's a pretty horrible fact. We talked about that at numerous community groups, and the community floated a bond measure, a tax bond measure on everybody's property tax. And those taxes were now raised to pay for an entire set of upgrades to the hospital. One of the primary earmarks for that funding was the cancer center.
I see.
So now the cancer center is being built. A new cancer center is being built. Right now we're in a very tiny space in a medical office building. We're going to have a 20,000 square foot facility that has a state-of-the-art radiation therapy unit in it and a PET-CT treatment planning machine that can double as a diagnostic PET-CT machine, and enough beds and chairs to be a real appropriately sized cancer center. I was able to recruit a wonderful young woman from UCLA who's like 36, young enough to be my daughter, and Erin Coppell, who has joined me, and that has just been a great joy to me. And Dr. Daphne Palmer is going to be joining as my radiation oncology director. She's also my wife.
Ah, I see. Well, that's helpful.
Right. We recruited her away from a medical center in Reno.
So, Larry, based on what you learned from your experiences here, what advice would you give another oncologist wanting to establish a successful cancer program in a rural environment?
What we learned was that there are a few essential elements for the development of a successful rural oncology model. One is we have to respect patients' fears of disorganized care, potentially incorrect therapy, and undue burdens on their families. Number two, you've got to use an electronic medical record. There has to be a coordinated, comprehensive support services program. A community support structure needs to be developed. People need to be proactive in the use of second opinions from disease-specific centers of excellence. A formal academic affiliation with a specific NCI-designated cancer center is necessary. The virtual tumor board program needs to be expanded, and a clinical trials program has to be part of this project as well.
Dr. Heifetz, thank you very much for joining me tonight.
My pleasure.
And please take a few minutes to read the full article, A Model for Rural Oncology, by Dr. Heifetz and co-authors in the May Journal of Oncology Practice. Also mailed with the May JOP was a special collaborative publication by JOP and the American Journal of Managed Care on payer-provider relationships in oncology. So please take a look at some of those very interesting articles too. And as always, send your comments about these podcasts to jopeditorsdesk@asco.org or comment on iTunes. This is Dr. Bob Miller for the American Society of Clinical Oncology. Thank you very much for listening.